Good morning. Can I welcome our panel to this session? We've only got a short number of questions to you, but as there are four of you, it'll probably take a fair amount of time to get through. If you find at the end there are additional pieces of evidence you'd like to submit, please feel free to follow up in writing. But for the record, I'd be grateful if the four of you would introduce yourselves.
Okay, I'm Richard Knight. I'm Director of the National CJD Research and Surveillance Unit and a clinical neurologist.
I'm Sheila Bird, Medical Statistician from the Medical Research Council's Biostatistics Unit in Cambridge.
I'm Paula Bolton-Maggs. I'm a consultant haematologist and I'm currently the Medical Director of the Serious Hazards of Transfusion National Haemovigilance Scheme.
Simon Mead, neurologist from the National Hospital, Queen Square. I'm an MRC employee. I work at the Prion Unit and I lead the National Prion Clinical Lead.
Thanks. If I can start off simply asking, is the UK blood supply currently more or less safe than that of other developed countries, say, for example, the US or France?
You're looking at me. Certainly, I would say yes. There are, if you're meaning, and I think you mean in terms of infections in the blood supply, safety, then the figures are very equivalent, or if not better. So I've got the current figures from the UK, which show that the risk of hepatitis B being in the donations is 1 in 1.3 million, hepatitis C 1 in 28 million, HIV 1 in 7.1 million, and there isn't a lot of data from other countries. We do have some from Canada and Australia and the Netherlands, and the figures are very similar. The rest of Europe, even though it's under the EU, doesn't have any up-to-date information that we could easily access. But infection isn't the only risk with blood.
Yes. Now, do prions currently pose the most significant risk to the UK blood supply, or are there other pathogens, known or unknown, that we should be more worried about?
I would say that prions do pose a risk, but we don't know exactly the nature of the transmission from PRP positives in humans. So we are obviously concerned that there is not a blood test for positivity for abnormal prions. So we can't protect the blood supply in the same way that we protect it from hepatitis B and HIV and hepatitis C, which are based on testing.
I think the only thing I would add, although this isn't my field, I'm looking from the outside, is as far as I understand it, as things currently stand, there are many other incidents, negative incidents related to blood, many more than happen with relating to prion disease, but you'd be in a better position to comment on that.
Yes, if I may. The biggest risk to people receiving blood transfusions is that somebody will make a mistake during the process, and that accounts for the largest number of reports that we have to the National Haemovigilance Scheme. And if I can show you, I could pass around this chart, which shows at the top our reporting categories, and transfusion-transmitted infection is this little blip up here. And these bars down here, all the mistakes that are made in relation to transfusion. So we're very pleased.
And these are different types of mistakes,
yes, they're when people don't identify the patient properly at the start or don't check the identity at the time of transfusion, and a whole raft of other mistakes. So that's our major concern is in that area, but there are several other categories. But in terms of infection, we're very pleased, if you like, that there are so few. But obviously, to the individuals that get the infections, that's not. You can't talk in terms of statistics.
But leaving aside the mistakes, Professor Knight said that there are other potential risks. So what are they?
We know about hepatitis B, C, E, some bacterial infections. I'm not an expert on the other fields, but I do know that there's a very good screening or finding program right across the world for emerging infections, and a report is produced every month by the Public Health and the Epidemiology Unit that's scanning for all the infections that might be a risk to the population. And for example, when West Nile virus became an issue in the blood supply, it was very quick that countries developed testing for that, although I don't think we do that as a routine, because it's emerged as an infection in the US, but not so much in England. But the Public Health and Epidemiology Services are looking at, if you like, the migration of infections like that across Europe. And so they're very much keeping their eyes out all the time to see emerging infections.
I mean, I suppose the point I was making was that you asked whether prion infection was the biggest risk. So you're asking in terms of magnitude, and I think that I don't know that is true. I think the difficulty, as has been suggested, is that for a lot of these other concerns, there do appear to be very good tests for them, because we understand about bacteria and viruses and so on, whereas we don't have, at the moment, very good tests necessarily for prion disease. So it's the difficulty of being able to protect the blood supply in the same way that is undertaken for these other agents. And of course, there are ways of treating and managing blood which reduce infectivity in it as well, that don't apply to prion disease. And in relation to other things like misidentification of patients, I mean, I still think it's important, because when you get given blood, the risk to you as a blood recipient is the risk of that action, whether it's infection or otherwise.
Okay.
Yeah, I think the main difference with prion disease is there is no test. And I think the scientific evidence, as I view it, points to a concern that maybe 1 in 2,000 people are silently infected. And we know from the animal research that if there is an infection in the body, that also includes the blood. And we have had hard evidence that variant CDD has been transmitted by blood transfusion. And I think the concern is, without a test, that infections are ongoing now that might build up a problem in the future, because we know the incubation times in these disorders can be so long, even over 50 years. So, you can be building up problems with infection that we have no way of picking up that may lead to clinical problems down the line. That's what I'm concerned about. And I think the priority is to move forward with studies to show whether blood tests can pick up this silent infection, and then look towards ways to try and prevent infections being spread if they are there. I think to say that there's a real risk of things happening now, I think we can be confident about clinical cases, or we can have certain confidence about clinical cases. What we cannot be confident about is whether infections are being transmitted.
So we're sort of categorising things into the sort of 3 areas: the human mistakes, those risks for which there are good tests, and those risks, prions or other unknown pathogens for which there are no tests. So that's basically where you draw the lines.
Although I think the uncertainty is a bit wider than that, because if you, for example, West Nile has been mentioned, if you wanted to know whether a human being is infected with West Nile, there are methods of actually doing that. So you can determine in many ways, like for HIV or other things, what the base population prevalence of these infections are. The trouble with prion disease is that we're working on uncertain assumptions. So, as Simon has said, for very good public health reasons, we work on the assumption that around 1 in 2,000 people are infected, but that's based on the appendix data, and we don't know for sure whether the appendix data really means that these people are infected, and even if it does, we don't know whether these people are infectious. And if they are infectious, we don't know at what period of time they're infectious for. So there's another uncertainty. It's the uncertainty of knowing how big the base population risk is.
Thank you very much. David.
Yes, so good morning. To ask you a few questions about tracking transfusion transmitted infections. My understanding is that the European Union published a series of blood safety directives between 2002 and 2005, and that we have the UK blood safety and quality regulations requiring serious adverse events and serious adverse reactions related to blood and blood components to be reported to the MHRA. In that case, why do we also have to have the serious hazards of transfusion shot scheme working collaboratively with other bodies. Can't we roll the two together? Wouldn't that make more sense, be more cost effective, more efficient, and mean that we've got less chance of dropping catches?
First of all, the SHOT scheme's been in existence since 1996,
right.
And the MHRA became the competent authority in 2005 because of the EU regulations. Now, they're mainly concerned with the quality of blood from the donation through to the laboratory, and then, if you like, what they're interested in. It doesn't stop at the laboratory door, because if there's anything that happens to the patient as a consequence of that, such as infection, that becomes reportable. Those things have always been reportable to SHOT, and when SHOT originally started up, it started up with public health surveillance to get infections. So there is overlap in that area between what the two organisations do, and we're currently working together to get a joined-up system, because we agree it makes a nonsense. However, there's a large body of work that SHOT does in terms of clinical events and teaching and training, which the MHRA don't do. And we link very much with patient blood management and putting the patient at the centre of everything we do. So if you like, it looks like this. There are things that the MHRA collect to do with quality and that we don't necessarily, but there's a large area of things that happen to patients that link with good patient management that SHOT's always done and continues to do in terms of teaching and training. So we want a collaborative system that would satisfy both those sections.
But you've just told us that we haven't got a fully collaborative system right now.
We haven't got one.
Right, so you're working towards it. But does
We're
that
meeting regularly with the MHRA to try and get a unified system.
Okay, following on from that, given that the incubation period for some infections can be several months or even years, how can we be sure that all transfusion-transmitted infections are actually recorded?
You're quite right. Quite often patients with an infection turn up much later after transfusion. They develop maybe symptoms, or they're found to have a marker of infection, say hepatitis B. And then if they've been transfused in the past, a great deal of work is done to see whether that infection that they have now links back to the transfusion or not. And that work is undertaken by the specialist department within the NHSBT. Or the blood services. So some of those patients may present now, but they acquired their infection 2 or 3 or 4 years ago. But because there's very careful records, vein to vein, if you've had a blood transfusion, we should be able to track it back to the donor. Then that research is done to demonstrate whether that infection in fact came from the blood donation or whether it's something that the person has acquired by a different route. And so often, or not often, but sometimes the patients that are reported to our system this year will have been infected a few years ago.
Okay, do you think the SHOT scheme should be mandatory, a requirement for all hospitals and blood establishments? Why not?
I absolutely do. The participation when we began in 1996 was quite low. It was 26% of hospitals, because people at that time, the culture of reporting when things go wrong wasn't very strong. But now SHOT has 99.5% of hospitals, NHS hospitals and trusts across the UK signed up to report. So it's very robust in those terms. What we don't know is whether people have incidents that they're not reporting because they don't think they need reporting, or for the very basic reasons that they haven't got the time to put the reports in. But it's very encouraging, I think, the level of reporting that we have.
Thank you.
Is there any reason for that tiny fraction not joining?
It's 1 or 2 hospitals. And we write to them and say, why aren't you signed up to report? And what
answers do you get?
Eh?
What answers do you get?
Oh, sometimes it's that they're linked to another hospital that does the reporting. So, for example, where there have been mergers of trusts and you have big hospitals that are entire unto themselves, but they're linked in a single trust, then they say that their teaching hospital colleague is responsible for reporting. And I'm just not sure how reliable that is, because really what you need on the ground in the hospital is people who are going to do the reporting, and usually these are called transfusion practitioners or laboratory or nursing staff. And with the current increase in pressure in terms of workload and everything else, I'm sure that not everything gets reported just because people haven't got the time to do it. But I think infections absolutely would be reported.
Soon.
Thank you. Good morning. I want to, if I may, look at the tracking potential transmission of VCJD. Now, the TMER is obviously looking at this, and I think Dr. Mead, you said there is hard evidence that it can be transmitted through blood transfusion.
Absolutely.
Fine. So there, on the back of that, is the government doing enough to prevent transmission? Should they be doing more? Something like leukodepletion. Sorry?
Leukodepletion's been in place for a long time.
Okay.
Leukodepletion was introduced by the blood services as one part
Right.
of the methodology that they hoped would reduce the risk of transmission.
It was universally in 1999, I think.
Yeah, it was, yes.
Okay, and it's still
Absolutely, because it has all sorts of other benefits to transfusion, quite apart from possibly being able to reduce the risk of...
Are there any other processes that we could introduce that would assist?
Well, I think the introduction of leukodepletion, it strikes me, was quite an interesting one because it was rather prescient in that it was done before there was hard evidence of transmission of variant CJD, which the evidence developed through 2004 to 2006. I sit on the ACDP committee and some other CJD committees, and I think it strikes me now there's scientific consensus that the key thing to move forward with is a prevalence study to try and develop a blood test, and that would be the biggest thing that would make further improvements. I think though I have to qualify it and say the point is we need to deal with the uncertainty. We don't know for sure that 1 in 2,000 people are infected in blood and are therefore posing a risk by blood transfusion. But the only way to find out is to start to run tests on that tissue itself and understand those tests better, get multiple tests even. The only way we can do that is by the next step is a scientific study that uses these tests in practice and starts to take it one step further. That's what I think is the key thing to decide.
If I could respond to your question retrospectively, I think a lot of measures were put in place. It wasn't just the universal leukodepletion. And as Simon has hinted, a lot of these things were done actually well before there was any evidence that blood was infectious. And in fact, there was a prevailing body of opinion when a lot of these things were done, expert opinion, that blood would not transmit prion disease. So I think a lot of precautionary measures were taken quite early on, actually, in a very admirable way.
Well, now that we know that blood can transmit prion disease, is it possible that other prion diseases could be being transmitted?
It is possible. There is no good evidence for that at the moment. And indeed, the TMER study looks specifically at sporadic CJD as well as variant CJD.
Okay. So when you say there isn't any evidence of that at the moment, is that because is anyone looking for that?
Yeah, well, in terms of, for example, in the TMER study, sporadic CJD is analysed in the same way, and there is no evidence at this moment that sporadic CJD, there is no identified case where it is reasonable to say that sporadic CJD is being transmitted by blood. And there are theoretical reasons for thinking it's less likely, but even despite that, it is being studied.
Thank you. And finally, obviously the TMER looks at the transmission via blood. Are there any equivalent studies that look at transmission perhaps through, say, surgical interventions? Or?
Well, there are various things that are done about surgery, and there's a whole parallel sets of what you might call enhanced surveillance.
Mm-hmm.
So there's a Public Health England occupational exposure study, so needle stick injuries, things like that. Surgery, we take in the CTAD unit, take detailed histories of all surgical operations. We get the hospital and GP notes where we can. We look through all of the records, and we have a database of surgical operations, and clearly we try to look to see if there's any connection between patients through surgical operations. Okay. We've done case control studies which involve obviously cases and controls and looked at surgical transmission, and we've done this in big studies with European colleagues. The evidence that surgery has transmitted variant CJD at the moment, we haven't discovered any good evidence for that. Sporadic CJD, there are a handful of cases that appear to have been transmitted by surgery and not for quite some time. The case control studies and other studies that have been done are a bit varied. Some of them produce evidence that surgery may be a risk and some of them don't. But they're very difficult studies to do.
Okay. Could you just...
The other thing I should say is that through the surgical incidents that may occur, Public Health England do of course have records of people who are supposedly at risk from this, and there are efforts, of course, then to follow those people up, and if possible, to do post-mortems on them in the event of death.
Okay, thank you for that. Could you just expand a little bit on the scale of that study into the surgical side of things? Is that every operation that takes place?
What we do when we see people with all forms of prion disease that we see, we get a lifelong history of every surgical procedure, and including dental procedures, and including suturing of wounds, things like that. And we collect that information, and then we get hold of hospital and general practice notes, and we try to see if there's any records of operations that we have, for example, missed.
Okay, so you kind of look back to the medical history, so someone presents with...
Sure.
Yes.
And then we have big databases, of course, with all of these on, and you want to know, in a way, whether two people who've been diagnosed with prion disease were, for example, on the same surgical list, or had an operation in the hospital at the same time. Of course, that sort of thing is extremely complex, and when you're looking for spatio-temporal clustering of things, as probably Sheila's a much more expert person than I am on this, it is very difficult to do, because, of course, the plain fact is that events do cluster.
Yeah.
You know, 3 buses do come along at the same time, and that can sometimes just be chance.
So what number of investigations back through medical histories are you conducting on an annual basis?
Oh, I see. Well, we would do it on every case of prion disease we know about, so it would be of the order of, something like 50 to 60 to 80 cases a year. And we will also, of course, have data on people who were referred to as initially as suspect cases who turn out not to have disease.
Okay. And is 50 to 80 statistically significant? Can you work with that as a number?
Well, I mean, I think the answer is that we've got when you're accumulating these things over time, we of course have got quite significant numbers now, having run the unit since 1990 and having pre-existing data going back actually to 1970, at least in England and Wales. And because we're part of European collaborative organisations, we sometimes have been able to do very big studies indeed. Although, of course, variant CJD, the studies will always remain small because, fortunately, relatively few people have been affected.
Perhaps I could come in on the VCJD patients. 67 patients received blood or blood products from those who had actually become VCJD cases. Now, of those, only 18 have died, having been at least 5 years out from that exposure. But we have post-mortems on only 8 out of the 18. And as Richard says, each of these instances is crucially important for gathering information about what is still a new disease. Yeah. And of those 8, half of them were positive for the abnormal prion. But of course, fully to understand that, we also need to know the age of the individual, the genotype, and so on. So almost there's, gender, birth cohort, and genotype are critical descriptions for each of these. We don't know necessarily even the genotypes of those who died, and that has an impact on whether the case, if infected, whether that individual might have presented in life. So I
was obviously addressing the surgical aspect,
Yeah. Okay.
And the other sort of network there is, if, for example, the chairman had been a VCJD case, and Mr. Metcalfe and I had both donated a unit of blood, then either the chairman ate his BSE, I did, or you did. So you and I are now at high VCJD risk, and we have to take precautions for the rest of our lives. I now die without having given permission in life for people to find out whether I am PRP positive. But actually I am, let us say. And you have to continue throughout your life taking precautions, whereas if I had given permission for the VCJD informative testing to be done in the event of my death, then hopefully, because we're just a very small network, you would have been let off taking these lifelong precautions. So the implications of giving permission in life are different for the different sorts of network and can have real implications for surviving individuals. It won't always be the case. If I were, the VCJD case and had given blood to both the chairman and to you, then the fact that you were negative still wouldn't let the chairman off lifelong precautions.
No.
So the implications of informative testing, permission for informative testing, are different according to the sort of network you're caught up in, which is quite a complicated thing to have to explain, but actually very important.
I apologise if this is touching upon someone else's area, but this is the last question. Who should be gaining that permission? At what point? At the point at which you donate blood?
Again, it depends how the network becomes identified. So some networks will have been identified to the CJD incidents panel and at that time might have had responsibility. The enhanced surveillance study, as I understand it, tries to get that sort of permission, but has not to date, so I'm told, been very successful in getting those permissions. But I don't know how the case is put, by whom it is put, and I don't see a public accounting of the numbers who've been asked, those who have declined, and those who have given permission. And I think, I don't know even if the CJD surveillance unit knows.
Well, I think it depends. I mean, the follow-up of people who are, as it were, at risk in some sort of way, and who may or may not have infection with prion disease is very complex. Some of them, when they are notified they're at risk, do have the opportunity of joining Simon's national monitoring study, and he can talk about that. Certainly, they're all the people who are significantly at risk, deemed to be significantly at risk, are informed that they're at risk. And they are given a standard letter which explains ways in which they can involve themselves in research, how, if they, for example, have an operation, tissue may be used for research. They could voluntarily donate blood, for example. They could give consent for autopsy or whatever. All of that is given to people. That's my understanding. I think largely it depends on how they're notified, but for some of these people it will come through their GP. If people don't wish to take part, then they don't take part. But they, and also the people who are thought to be at risk but not informed, because their level of risk is thought to be very uncertain or low, they are flagged. And in the event of their death, my understanding is that local information services flag that death on the electronic health system. There's then, I think it's called Health and Social Care Information Centre, and something called the Patient or Personal Demographics Service identify these deaths. They notify Public Health England, and then depending on what category they're in, they will be notified to us in the CJD unit or to Simon and the National Prion Clinic, and things follow that course. I have to say that it is quite correct that trying to get autopsies on these people who are thought potentially to be at risk is very difficult. And it's my understanding from the interim report of that system that in 2013, I think there were 11 deaths in this kind of enhanced surveillance cohort, and as far as we know, no post-mortems were done in it. And speaking personally, the difficulty is that if I'm informed, as indeed I was very recently, of somebody who was in this category who we would be interested in, they had died. It was a Friday at lunchtime, which is in any system the worst time you can be told anything. I rang the GP, and the GP was not working that week. None of their colleagues were able to deal with the problem, so I was able to find the local hospital, rang the local hospital, and indeed spoke to one of the doctors, who, needless to say, was not the doctor who knew anything about that patient, but they gave me the details of the bereavement service. I went there and I found out a death certificate had been issued 2 days before and that no post-mortem consent had been given, and there was no way of my contacting anybody further until Monday or Tuesday, when it would have been too late. So it's a very inefficient system in that way. On the other hand, personally speaking, this is now my personal view, I think mandatory autopsy, which is true in some countries in the European Union, I would be very opposed to that. I think, although there are very clear public health benefits to this information, I think there are lines where personal choice does count.
We're covering some of that.
Okay, sorry, yes.
David, if you...
I think it's just about covering everything.
Sorry, David.
I'm interested, and perhaps Dr. Mead can help me with this. You've got this cohort of at-risk patients, or not necessarily patients, individuals. To what extent is there surveillance from a neurological basis of that cohort?
Yes.
Are they invited for regular checks, neurological checks?
Indeed. I think perhaps what I should make clear first of all is this at-risk group that I'm involved in following up is a very, very small proportion of the total number of individuals that are at risk because of variant CJD and blood products. The small group that I'm involved with are those that have been exposed through a transfusion of a whole unit of blood or more. Okay. Now, given the small numbers, this means that me and my team have the capacity to actually go and visit people in their own homes and have a full discussion with them about the science behind it, why we're interested in working with them, and try and engage them to try and find solutions to the problems and uncertainties we face. Now, of course, many of these people are really annoyed about what's happened to them and the risks that they've been put under, and that makes it difficult to engage. But the majority have wished to participate, and we build a relationship. Therefore, we hope that we will learn of any symptoms of any illness that develops, and that people will be more willing to volunteer blood samples and tissue, should the worst happen and they were to die of another illness.
You don't do any genotyping or anything like that?
Yes, we do. Yeah, so we've genotyped every patient that is offered so we can extract DNA from a blood sample.
Yeah.
We've taken blood samples from all those that have been willing, in case anyone in the future was to develop prion disease. We could look back and see if there was a blood test, whether it was positive at that time, and that's a very valuable resource, but thankfully that hasn't happened yet. And through this work we've enabled a relatively high autopsy rate from this group where individuals have passed away.
Even when they died of other causes?
That's right. But I think it's only...
Sorry, I'm misunderstanding something. I thought I heard earlier that no autopsies had taken place with
that's a different group, I think.
That was a separate group, yeah.
Right,
the enhanced surveillance groups are complex. There are many different groups. Simon's talking about a very specific group.
There's 8 autopsies from this group of 18 or so, some of those were individuals that developed variant CJD, 3 of them. And the remainder from individuals that died of other things. But we only obtained those. The point I wish to make is the reason we obtained in life consent to an autopsy was the fact that there was a high level of personal engagement with a small group of individuals. Yeah. The much wider group, including haemophilia and people at surgical risk, several hundreds of individuals that I think it's worth making this point about surgical risk. The actual concrete harm that's going on at the moment when there's a look-back exercise after a diagnosis of variant CJD, is all the contacts of that patient are then notified that they're at risk, with no opportunity of a blood test to confirm or not whether or not that risk is real, and an indefinite prospect of a potentially incurable disease. And I think it's a great shame we haven't moved faster towards ways to adequately sterilise surgical instruments to avoid the need to have to write these letters. I agree with Richard about the difficulties of scientific epidemiological study in this area about surgical instruments, but there have been, on occasion, there have been several manuscripts that have suggested that there is an increased risk for CJD in surgery, although there's no scientific consensus on this at the moment.
First of all, you are keen, as I understand it, on mandatory post-mortem of the at-risk group.
I've suggested that this suggestion was made about 10 years ago, that this is such an important and difficult disease, and the consequences of BSE are something we visited upon the world, that we really need to try to understand variant CJD. And I think it is regrettable that much valuable evidence is actually buried or cremated. I appreciate how difficult these conversations are with patients, and I think when there's a specialist group making those conversations, as Dr. Mead has said, there is actually the potential for a higher consent rate. But the practice is that overall we have very little post-mortem evidence from the set of highly at-risk individuals. I mean, I would like there to be almost an annual accounting of the types of VCJD at-risk network, how many people within those networks have survived for at least 5 years from the putative exposure, how many have died at least 5 years out, how many post-mortems there have been, so that we can actually see for each of these groups what the information accrual and the loss of information is.
And you're looking at this from an epidemiological position in terms of population prevalence, in which case, if we had a satisfactory blood test, we wouldn't need that, would we?
Exactly. If we had a satisfactory blood test, then of course the reliance on post-mortem evidence would not be as great as it currently is. So a research priority undoubtedly is a validated blood test. In the first instance, its performance need only be sufficient for surveillance. So instead of having done the prevalence study in appendices, that study could be, in essence, repeated in anonymised testing of blood samples from blood donations or whatever to find out the prion positivity in blood if we had a validated test.
But post-mortem would tell us whether the carrying of prions had resulted in lesions.
Absolutely.
So there is a further step.
There is a further step to know, as Dr. Mead has said, about positivity in tissues or blood in life, and then what the pathology is at post-mortem gives the more complete understanding, and each of those instances is extremely precious.
So Professor Knight, you look as if you
I just wanted to maybe
something.
clarify the point that one of the difficulties you may have understanding this is that the people who are designated at risk fall into multiple categories. There are those people who have been notified and know they're at risk, but there are lots of people who are designated at risk but aren't notified, so they're an entirely different group. And the comments that Simon has made relate very much to those people who are notified and know, a very specific subgroup. And the comments that I were making largely referred to these people who don't necessarily know that haven't been notified.
But it's almost infinitely extendable. Yeah. I mean, everyone who's eaten a beef burger over 50 years.
Well, I think there is also another comment I'd make, and that is that blood test is, I would agree, extraordinarily important. If you had a blood test that really worked, that would be a great boon in all sorts of ways. But what you really want to know is, because the CJD surveillance system should pick up people who develop CJD. So in a way, if there are people at risk who develop variant CJD, the standard surveillance system will pick those up, I hope. The difficulty is those people who are infected and have subclinical disease. That's who we want to identify. And of course, the real difficulty is if you have a blood test that is validated in detecting an abnormal result in somebody who's clinically ill, the question is, will that work in someone who is subclinically infected? Yeah. And that, of course, is difficult and also difficult to validate. And if somebody is subclinically infected, will the blood test be positive throughout the whole period of subclinical infection, or only become positive at a particular point? And that's a very difficult thing to validate. The other thing I should say is that we have tried other approaches to this, and one approach, for example, was to go through accidental deaths, and the coroner system, at least where I come from, would be the procurator fiscal system, but in England, the coroner system, to try to suggest that material at those kind of autopsies could be examined for infection in the population. And unfortunately that proved impossible because the coroners in general did not wish to take part in that.
Can I just have one last question, if I may? Might there be a case for at least looking at post-mortem material from those who are certified as having dementia at time of death?
Well, I think that, of course, that's quite a difficult business because many people have dementia.
They do.
Many people. And I don't know how you'd go about doing that on a global scale. What we wanted to do in our unit, because we're very well aware, first of all, In sporadic CJD, the age-related incidence of sporadic CJD drops off sharply with age, which doesn't make sense for a supposed neurodegenerative disease. And it could be, of course, there's under-ascertainment in the elderly. 2 out of 3 of the blood-transmitted cases were in terms elderly, and of course it's the case from the appendix study that one cohort, which would now be entering the sort of mid-50s to mid-70s age range, had a significant set of positive results. So there has been a question as to whether disease is being missed in the elderly, and I think the only way you could really go about doing that would be to try to define an area which was manageable, and to try to identify dementia in that area and look at atypical dementia and try to investigate those in more detail. There are dementia studies going on in various parts of the country. I mean, we've had collaborations with a fairly detailed one in Cambridgeshire, for example. But we have recently decided we'd like to do one in Lothian and perhaps collaborate with the Cambridgeshire setup, whereby we would offer in detailed investigations in life and try to get a high autopsy rate in atypical demented illnesses. We've submitted a proposal to the Department of Health and we're waiting to see what would happen. I don't see how it could be done on a national scale at the moment.
Thank you very much.
Right. Just following on from that answer, you've stated that you're confident that there is little underreporting of variant CJD. Well, yet the answer you've just given seems to indicate that it's difficult to distinguish variant CJDs from certain forms of dementia. So how can you be so confident?
Right. Well, I suppose the answer is that if you ask any honest surveillance system, are there missing cases, there's only one answer: yes. The question is the magnitude of that.
That's right.
So obviously what we try to do first of all is to have overlapping methods. So we get clinicians to refer as suspect cases, and we deliberately leave it very open. We don't have any very set criteria. If somebody thinks it might be prion disease, then they can refer a case. We ask pathologists to refer any cases to us that they come across. We get death certificates with certain rubrics on them sent to us in batches, and if there's anything that we think needs to be followed up, we try to go through the medical records. We have an embedded spinal fluid laboratory which does tests for these diseases, so we know, and that's a national laboratory funded by the Department of Health, so we know when clinicians are suspecting a case because they ask for this CSF test. It's part of the routine diagnostic procedures. And of course, we are sometimes notified of cases through families who approach the CJD Support Network, a charity. And we've done various things to try to ascertain we've not missed cases. So we did a big retrospective study of death certificates in England, looking to see whether we might have missed cases before 1996. And all I can say is that in general, with the neurological community being very aware of this situation, we think we are probably not missing many cases. And the disease itself is a fairly striking disease. Most neurologists, if they see it, will recognise it as something unusual, or they will recognise it as a prion disease and let us know. If you look at what's happened in the UK, the number of people who have been diagnosed as having any form of CJD in total has gradually risen, and the annual mortality rate, which is rather more important, has gradually risen over time, suggesting that people are identifying cases more often. And if you look at things like the ratio of referrals of suspect cases to proven cases, that ratio has dropped at the same time as the number of cases has gone up, which indicates that clinicians in general are getting a bit better at this. And alongside this, there have been the introduction of much better diagnostic facilities and diagnostic tests like MRI and CSF proteins. So I don't think that we can be absolutely confident, but we certainly do, I think, have as good a surveillance system as is practically possible. If you look at what happens in other countries, the only real comparison we have with is sporadic CJD, and we have annual mortality rates that are broadly similar to most other countries, and the countries that now are embedded in collaborative networks are very extensive including Canada, Australia, Japan, Israel, the whole of the European Union virtually. Very widespread. And indeed, if you look at those countries, the annual mortality rates of sporadic CJD have risen almost exactly in the same way as they have in the United Kingdom, again suggesting that it's all to do with improved surveillance rather than cases of variant CJD being mistaken as sporadic CJD, especially if you compare with Australia, where there's said to be a very, very low risk at all of any kind of animal prion disease. The way in which annual mortality rates have changed in Australia has very much mirrored our own, suggesting that, again, the figures of sporadic CJD don't hide any variant CJD that we've not discovered. The reason for being interested in the elderly is because it's quite clear, I think, this is an average statement about the health service, that if you are, say, 45 and you develop a serious dementing, disabling neurological illness, you're almost certainly, in the United Kingdom, going to see a neurologist. If you're 90, you might not see a neurologist, and therefore neurological expertise may not be good in that particular set of clinicians, and therefore we are interested particularly in whether we're missing cases in the elderly, but particularly cases of sporadic CJD. That's what we're most interested in. But along the way, of course, we could ascertain whether we have missed cases in variant CJD.
Thanks. That's a very comprehensive answer.
Might I add that I think there's a very specific reason to be concerned about variant CJD in the older birth cohort, and that is because of the work that my group did on dietary BSE exposure, which showed that the 1940 to 69 birth cohort was more exposed than the younger birth cohort. And that prior, if you like, that prior expectation is actually borne out in the prevalence data in appendices that have just come to the fore. Now, we haven't got enough testing as yet in the older birth cohort in the appendix study. We have tested fewer than 9,000 in the 1941 to 65 birth cohort, when we had tested only about 9 to 10,000 in the younger birth cohort. That was the prompt for the second surveillance study in order to make the information more precise. That prompt has not been followed up in the older birth cohort, and so I think we have particular reason to be on the lookout for whether some form of VCJD might present in the elderly. The other consequence of the dietary data was that because of the mismatch between the birth cohorts that consumed and the birth cohorts that became clinical cases, the implication of that is that there is age-dependent susceptibility to a dietary exposure progressing to clinical disease. And it was the dietary data that allowed that separation and that inference to happen. And that's why we also are fairly confident that we will not have variant CJD cases in those born 1990 and later. We can't be sure yet. We haven't had any as yet. We'll be a bit more confident if we get through 2015 and still don't have a 1990 born VCJD, and I'll be very confident if we get to 2020 without having had one, that it would be a vindication of the prediction from the dietary data. And so that's why I'm concerned that the figure 1 in 2,000 is, accepted as the general summary of the surveillance data. I think it is premature to conclude that there is not a higher PRPSC prevalence in the older age group. And we need further testing in that age group, in my view.
You've partly covered this, Professor Knight, but Professor Ironside said you had got methods for improving the surveillance of variant CJD in the elderly. Do you think you could tell the committee a little more about what methods you've got, or what improved methods of surveillance you've got?
So that Professor Ironside said that we...
He said that your unit had recently proposed a new approach to CJD surveillance.
Yeah.
And what has been the Department of Health's response to that?
Well, the Department of Health response were intrinsically interested in such an idea and asked us, invited us to submit a proposal, which is what we've done. And that was fairly recently, and my understanding is that proposal is being considered. And my understanding of the consideration of it, although I'm not in the Department of Health, is that they are interested in such a study, but obviously it costs money, and therefore it has to be considered in terms of its benefit and its cost.
And can you just tell us a little bit about how it would vary from current surveillance?
Well, I mean, at the moment what we do, we ask people to, it's a passive surveillance system in the sense we ask people to refer, and they refer through a national system to us and the National Prion Clinic, but it's up to those clinicians to actually refer the case. As I've said, we've got various checks in place like death certificates. So if we get death certificates that suggest something a bit unusual or even actually have got CJD on it and we don't know about them, they might be an elderly person, and we would investigate that by getting a hold of their medical records and finding out more about it. The proposal that we have is that we want to, within Lothian, which is the region where I work, and its associated satellite units, there's quite a nice setup of memory and dementia clinics and services that are interested in investigating memory and cognitive impairment in the elderly. And what we want to do is form a collaborative network so that when they see people, they try to categorise these people as clearly as possible. And to be fair, a lot of these people are going to have classical things like Alzheimer's disease, which are usually very easily clinically distinguished, usually from prion disease. But if they see people who they think have unusual dementia or some way it's a bit atypical, then we will collect these people, we will go and visit them, we will take detailed clinical information from them and examine them. We will offer things like MRI, which might not be always done in elderly dementia patients. And we will try to get a high autopsy rate, because the autopsy rate in elderly dementia is very low indeed. And in doing that, we will try to link up with maybe one or two other systems, and one I've mentioned is in Cambridgeshire, where there was a dementia kind of project of sort of similar sorts dementia register going on. So it's really to try to identify all people contacting health services within a region who have dementia, trying to select a reasonably defined subset, trying to investigate them in more detail than would normally happen, and trying to get a much higher autopsy rate than would otherwise be the case.
Right, last question from me. There's been a study in France where healthy monkeys have been exposed to blood with variant CJD, and they've developed symptoms that are atypical of prion diseases. Are there any implications in that study?
This study in France, was?
I'm not sure if I've got the name in...
but this were people who were exposed.
No, it was monkeys exposed.
Monkeys, macaques, yeah. It was the macaque study. Oh, I see, yes. Yeah. The macaque study. Well, it's difficult for me to comment on the macaque study because, as far as I know, it's not been published.
Oh, right.
And
so
therefore,
we're in advance with our notes here.
It's terribly difficult. People are aware of this study because, for example, some of it at least has been presented at scientific meetings, and so I think there was an abstract from a scientific meeting which describes it. I think many people are not quite clear what to make of this result, and I think there is uncertainty as to whether it represents an unusual form of prion disease or not. But without more detailed examination of the material, it's very difficult. My understanding is that the illness in the macaques is more like motor neuron disease than prion disease, but I don't know the details. Certainly, the implications of this study are known. For example, the Haemophilia Centre Doctors Organisation know about it because they would be a group, obviously, who could be potentially at risk. If you were to extrapolate what has been said about the study without knowing the details of it, and it were the same for humans, presumably you would look to see in humans if they had some form of a motor neuron disease-like illness, and that would require rather different methodology. But as I say, without having the published details, it's extremely difficult to comment on, and I know that people who have heard this discussed have some uncertainty as to what the study actually means.
Thank you.
Steve, thank you. It's to you mainly, Professor Knight again, I'm afraid. We had some really powerful evidence from Ms. Christine Lord, who of course established the Justice for Andy campaign after the death of her son. We've had both written and oral evidence, and she suggested that in some cases the NCJ RSU may have misclassified some cases after death, and in fact she named 7 examples. Now they've all been redacted in the evidence,
Yes.
and I know you can't talk about the specifics of the individual cases, but she claimed that these 7 cases hadn't been diagnosed as VCJD. Had they been?
Well, I think, obviously I don't know which specific ones in that particular submitted evidence. The answer is that I have been to her website and I have looked at all the lists of names that she has on the website. And first of all, there are lots of people on that website named who do indeed have definite or probable variant CJD. There is certainly one name on that website that has what we call possible variant CJD, although we thought it was very likely that this person had variant CJD. There were lots of names on that list who had proven genetic CJD, lots of names on that list who had proven human growth hormone related CJD, and therefore there were certainly names on that list who, as far as I know, have never been thought to have variant CJD, and certainly therefore would not be included in our statistics. There were also names that were duplicated on the list. So, for example, in one version of the list there was someone listed as having variant CJD, and then they were listed again, one under their married name and one under their maiden name, so that may explain some of the confusion and duplication. There were also people who were just listed something like it said 37-year-old housewife, Cambridge or something, and of course I have no idea what that means. It's impossible for me to comment on that. But I suppose the question that you're really asking is, in relation to what I have read on the website and in her book, have we deliberately misclassified cases? The answer is no. But on the other hand, I suppose if I had deliberately misclassified cases, that's what I would say now. We haven't. And I can't...
Well, you're in front of a select committee, so you're taking quite a risk if you are deliberately
I can't think of any motive that I personally would have for doing this, to be honest with you. And our real aim has been along the way, by all of our overlapping methods and investigations, to make sure that we actually identify all the cases as far as possible, and we would not be wanting to do that. If the question is, have we misclassified cases accidentally, well, that's a bit difficult. It depends what you mean. And all I can say is that we have a case classification system, and like every disease, you have to make judgments. So if I see somebody in the clinic and I decide they probably have multiple sclerosis, there is going to be a certain amount of doubt. And if I say they probably have epilepsy, there's a certain amount of doubt. So when we say that somebody probably has variant CJD, we think it's actually extremely likely that they have variant CJD, but no, we're not 100% sure. And if we say that somebody, on the balance of everything, is very unlikely to have variant CJD, then it's very unlikely, but without actual final proof, it's impossible to say. We think that the diagnosis of probable variant CJD is a very probable diagnosis. I wish my diagnoses of probable epilepsy or probable MS were as good as that, actually. It's a very high degree of probability. And we do certainly do our best to classify cases in a fair way. So if we see somebody and we don't think that it's variant CJD, but there is a possibility there might be, we have a separate classification system for that. And we keep records of those people. There are not many people in that category at all. As I've said, if one makes a statement that there are 177 definite or probable cases of variant CJD, We have classified 4 people in the whole of this time as having possible variant CJD, and there have been 1 or 2 other people that we've had a great deal of uncertainty about, but on balance we think it's very unlikely they've got variant CJD, but we can't prove it without autopsy material, and not everyone has an autopsy. I don't think that there's any... I don't think that we've missed huge numbers of cases. I think, maybe 1 or 2 here or there is possible. And I think if the cases have been misclassified accidentally and inevitably because of poor information, it's a very small percentage indeed.
Okay. I do want to ask you about the processes that you follow to make sure that you get that right. But before I do that, I've just got a couple more specific points that Mrs. Lord raised. Firstly, have there been any cases of genotype MV who have had VCJD?
Well, the answer to that is very simple, that all definite and probable cases as they're currently defined who have been tested have been MM. Not everybody has been tested. The vast majority have been tested, but not everybody has been tested. So all definite and probable cases, yes, have been MM. We have got a possible case, as I think I gave you in written submission, who we think is pretty likely to have had variant CJD, who was MV. And there are well-documented cases of variant CJD infection, at least we presume infection, from, for example, a TMER study, haemophilia, and the appendix study, who've been MV or VV. But no definite or probable case, as they're currently defined, has yet been shown to be other than MM.
Okay, does that mean that you would, if someone was MV, you would automatically rule them out from having VCJD?
Certainly not. That would be completely wrong. We've always been of the opinion that MV and VV individuals are likely to be infected. We've always been of the opinion that some of them will develop disease. We can't know for sure, but we've always thought that's reasonably probable. We've always thought that it's likely, on the basis of a variety of bits of data, that people with MV or VV, if they developed disease, would do it with a longer incubation period. We can't be sure about that, so we'd expect them to appear later. And we've also been of the opinion, particularly based on certain animal experiments, that subclinical infection, and I mean genuinely subclinical infection, where people might never become ill at all during their lifetime, would be more likely in non-MM genotypes. But we've never for 1 minute said that people who are not MM won't get variant CJD.
Okay, and then the last sort of specific
you look
question...
puzzled by that, sorry.
No, I was thinking, okay. There's also been suggestion that an individual might have died from VCJD infection who contracted it via blood transfusion after the introduction of blood safety measures in 2002. Are you aware of that? Is there any evidence of that?
When you say after the introduction of blood...
who received the blood transfusion after 2002?
No. I mean, I think there's a difficulty here that... I'm not sure what specific case you are referring to, but I think the difficulty here is that the attribution of cause of prion disease is in general a matter of judgment. So we know that there are lots of people who've developed variant CJD who don't appear to have any risk factor other than the consumption of BSE contaminated food, but there is no individual in whom we can prove that they ate a particular piece of contaminated food. It's just impossible. We have no way of doing that. And likewise with blood, it's not that we have had a unit of blood in which we've detected infection and that person has then been infected. When we first had a case who had had a blood transfusion from a donor who later went on to have variant CJD, and then they developed variant CJD, it seemed likely that that was the cause, but actually when we worked it out statistically, it was not absolutely certain. But then when we got the other 2 cases, and indeed one pair had been infected by a donation from the same donor. At that stage we were instructed that the chances of this happening by chance were something like 1 in 100 million or something like that, in which case you have to go along with that. But there are people who have variant CJD who have had a blood transfusion in the past, and then of course they've developed variant CJD, and the donor of that blood has never developed variant CJD. The question is it possible that this person developed variant CJD because of asymptomatic infection in that donor, or is that just irrelevant? And you have to make some kind of judgment on that score. We have, I have to say, looked at that carefully recently, and I submitted a pre-publication paper to the committee, which is not in the public domain, whereby we tried to analyse all of our cases to see whether there was any justification for thinking that somebody who had variant CJD, who'd had a previous blood transfusion from a donor not known to have variant CJD, could in fact have got it through blood transfusion. And our conclusion was that there was no very good evidence that any of those cases had obtained it through blood. But if you wanted to ask me and say, is it possible? Well, of course, the answer is yes, it's possible.
Okay, so what controls are there in place to make sure that you do diagnose things correctly with VCJD? And is there any peer review of that? For instance, did the MRC...
Well, I think the answer is what happens certainly within our unit is we have a case and we collect information and we then classify the case diagnostically according to a diagnostic classification protocol. That protocol has been published in peer-reviewed journals, is being presented at a wide variety of scientific meetings, and it has also, I have to say, been discussed endlessly with international colleagues. There's been European collaborative systems in place for a long time now, and the diagnostic classification of cases is one of those things that when it appears on the committee agenda usually produces a feeling of sinking hearts, because you know it's going to be a very long and difficult debate to try to get everybody to agree on the classification criteria. But in the end, they're very rigorously discussed, very rigorously reviewed, and we've come out with very robust ideas. And then those classification protocols are put into practice. So we apply them to patients, and then we follow them up and see how well they work, and therefore we revise them. And indeed we've had revisions of them. So we had a revision, I'm trying to remember exactly when, 1998 I think, where we revised it to include 1433 protein in the CSF, and then more recently we've revised it to include MRI, and we're about to revise it again to include other diagnostic tests. And so there's a great deal of rigour in that. In what happens in the unit, if there are difficult cases, and sometimes there are, is that they are classified independently, completely independently by me and my colleague, Professor Will, and if we agree, that's fine, and if we don't agree, we have to sit down and discuss the classification. And I should say that our whole methodology has been reviewed on more than one occasion. We've had meetings with the Department of Health, who clearly are main funders, and they have had external and international review members who have reviewed our methodology. So I think it's fairly rigorous. We do, of course, have close colleagues in the National Prion Clinic, and we meet monthly, and we go through all of the referred cases with the National Prion Clinic and discuss our diagnostic conclusions mutually. So as far as it can be, I think it's a fairly robust process.
Okay. And lastly, very, very quickly, you've talked about the increase of sporadic CJD, and so I'll get to that. Is there any evidence to suggest that that might be at all BSE related?
Well, there was no evidence to suggest that, and I think that there is evidence a bit against it. For example, there are countries like Australia who have actually got slightly higher annual mortality rates for sporadic CJD than we do, which if we were hiding variant CJD in our sporadic CJD would be a bit difficult to explain. And as I've said, the annual mortality rates for sporadic CJD have increased in the UK, but they've increased in an extremely parallel way. I mean, I did write down some figures on the anticipation that you would ask me this, but for example, over the same sort of period of time, we went from 0.39 annual mortality rate to 1.37 in sporadic CJD. So that's a fairly big step. But Germany went from 0.44 to 1.1, Italy 0.48 to 1.76, Canada from 0.07 to 1.44, which is a huge increase, and Australia, where there is no scrapie or BSE, at 0.96 to 1.5. And actually, if you look at the mean rates for the UK, they're lower than Australia. So if some cases of variant CJD are masquerading as sporadic CJD, it must be a tiny number.
Yes. And I agree with a lot of what Richard said. And first, perhaps I should say, attending many of these monthly meetings where we coordinate cases, I don't have the slightest doubt about the integrity of the classification system. Whilst there might, of course, be debates on individual cases, I think it's done entirely honourably. However, I guess I'm not so confident that some CJD we're seeing could not be BSE related. I think there are very strong currents going on here in terms of generally increased awareness of the disease and better ascertainment. I think there's this reality that the vast majority of elderly people never even get a diagnosis of dementia, never mind to see a GP to get a diagnosis, never mind to see a neurologist. And so there are big questions, a massive under-ascertainment in the elderly could be going on. Over the last few decades, there's been huge increases in CJD diagnosis in the elderly, and I don't think that process has come to an end. Now, of course, one can make international comparisons, but with all these currents going on backwards and forwards, I think it's very easy to conceive of a proportion, which could be a significant proportion, of prion disease in the elderly, that increase being BSE related. I think it's very difficult to be certain that that's not happening. It would have to be a very large increase for it to be obvious. That's my view in any case. I would also, if you'd allow me just 30 seconds to make some comments about some other things that Christine Lord said that were relevant to the MLC prion unit, because she did make some accusations about blood samples that I would like to counter, if that's okay. The situation with blood samples is particularly complicated. There are very few. Many of them are separated into different fractions. These go into different tubes with different chemicals, and many of them have different consent requirements based on what the families or the patients themselves told us when blood samples were taken. And that puts a lot of binds on us in terms of how we can distribute those samples. I know from discussions with Professor Collins when Christine was keen that we moved samples around to different companies, he spent many, many hours trying to negotiate this with Christine in the context of some of these problems and constraints we had. And we really do bend over backwards to try and take into account the wishes of loved ones who have donated samples.
And I'd just like to continue the question about the relationship between the government and the surveillance unit and the patients. First of all, can I just clarify, when a patient is referred to the surveillance unit, I take it that they've already had a diagnosis or a suspected diagnosis from their own clinicians?
Yes, usually, although clinicians sometimes do ring us up, and I'm sure they ring the National Prion Clinic up to discuss a case that they've not formally diagnosed or told the patient or relatives about, because they're a bit uncertain and want to know should they be thinking along these lines. But when it comes to us, and what we try to do is go and visit the case personally, interview the family, examine the patient, collect all the clinical data. We do that only with consent of the family, and clearly a visit by the National CJD Research and Surveillance Unit can't be undertaken with consent unless the family and or the patient know that CJD is being considered. So yeah, the clinician at that stage has told the family and or patient that CJD is either what they think or suspected.
And just to be clear, that the surveillance unit would never be in the position that they would be the first contact that a family would get to tell them.
You mean
they would already know that from the clinician. So the first that they'd heard of VCGD would not be from the surveillance unit.
No, we would never. All I can say is about our unit's practice. And our unit's practice is that we would never be able to arrange a visit and speak to the family and all the rest of it without their consent. And that would, of course, be initially after they've been told what the suspected diagnosis is. Of course, it may be that the diagnosis is not confirmed. It may be that it's just a suspicion. Yeah. And there are cases we visit who don't have CJD in the end. Yeah.
Okay. So what is the next stage then for you contacting the patient and or the family?
If we get told of a case, if they are alive, because sometimes we are informed just shortly after death. If it's after death, we usually wait, and we wait a bit of a time, and then we usually contact people through their GP, the family through their GP, and arrange a visit to go and visit later on to speak to the family. If they're alive, what we do is through the local clinical services, because these people are almost certainly at this stage on a hospital ward somewhere, we arrange a visit to that patient on the ward, and the local team arrange for the family to be there so we can see the family at the same time, and then we go to visit.
Okay. Can I just ask what the members of staff from the surveillance unit who carry out the questioning, and the visits, what training do they get to deal with what is clearly a very sensitive situation for quite a vulnerable family?
Right. Well, I mean, sometimes the visit is conducted by myself or Professor Will, in which case I suppose the only training that I can really say we've had is that we've been dealing with prion disease since 1980, and we've been clinical neurologists for 35 years, but that's the only training we've had. In terms of the junior staff that go out, these people are usually fairly experienced trainees. They're people who've obviously medically qualified. They've usually done 2 or 3 years of general medicine and usually done a couple of years of neurology. And so they have a lot of clinical experience in dealing with patients. And of course what we normally do is that when we choose these individuals, we concentrate very much on their interpersonal qualities. We want people to go along who are going to be sensitive and good at dealing with patients, not simply people who are interested in the science of this. We do, when we employ a new person, overlap, so that for the first few visits they go along with someone who's been doing this for 2 years, or one of us, so they see how it's done and get some, as it were, apprenticeship training, and then they go on their own. Very often when they go accompanied by one of the unit's nurses. Both of them are very experienced senior nurses, one of whom had training in psychiatric nursing and one of whom had a training in neurological nursing. So again, they have a lot of experience of talking to people.
Okay. Can I ask, you'll be aware that Ms Lord had spoke about this in her evidence as well, and about that relationship and that experience. Can I ask, have you ever had complaints to the surveillance unit about visits and the conduct of staff on visit to families and patients?
I suppose I should be able to answer that question absolutely, but it's a long time. I can't recall any time when I've had a specific complaint from a patient or family about a visit. No, I can't recall that.
Is that something you would keep a record of?
Yeah, of course you would. And I mean, there are times, and I'm sure Simon will say the same thing because we discussed this at our monthly meetings as well, there are times when comments are made about things that have happened, but very often when you look into it, it's very difficult to find anything that actually happened. And the trouble is that sometimes it's actually very confusing. For example, one particular incident where somebody said something that wasn't quite right, when we looked into it, it was actually a member of the local clinical staff and not one of our units, but the patient's family got them all a bit mixed up. So sometimes it's quite difficult, but never anything major. I've never had anybody come back and say, that they found the whole process unacceptable. And in fact, my own experience, and this is because of course we do talk to our junior staff, because after all we are sending them out to other people's hospitals for 2 or 3 years, and they're seeing patients who are seriously ill, who are going to die, families who are very distressed. Doing that kind of job for 2 or 3 years has effects on people, and they're relatively young people, some of them. So we do, of course, go into it in some detail, and what they say is very much my own experience, and I'm sure Simon will probably say the same thing, that a lot of families actually really like this process in a curious way. They find some kind of solace in going through the patient's life and everything that's happened and talking about it, and quite often you end up with little cul-de-sacs where they remember some kind of family gathering, and you talk about that, and actually I think a lot of them find it quite helpful. And certainly the technical side of things, it is, from our point of view, a joint deal, this. We want research information, but we also are going to give them information. I'm sure that the same thing probably Simon would say. They get a lot of information from experts in their disease, which they would otherwise perhaps find difficult to get.
Okay. I'm aware we're running over, so I'll just ask one final question. One of the other things mentioned by Ms Lord in our evidence was that families had been asked not to speak publicly about the fact that their relative had VCGD or specifics about the case, for instance, if that relative had given blood or not before. Can I just ask for your response to
I thought that was probably the most astonishing thing. I have absolutely no idea as to the basis of that comment. I can categorically state, of course I can't give you any evidence, but I can categorically state that we would never, ever give such advice, and I can't think for the life of me why we ever would give such advice. I can't think what on earth would the purpose of that would be. Anybody who knows anything about me is hardly going to suspect me as an agent of the establishment.
What an accusation.
Yes.
Might I just add that in 20 or so years of dealing with TSEs, I have had nothing but absolute admiration for the quality of the work done by the CJD surveillance units, for the protocols that it has introduced and that are adopted internationally. I found that the evidence very surprising, I have to say.
Thank you.
Yeah, and I agree. To keep things short, I agree entirely with Richard. I found those comments completely surprising. We monitor very closely the work of the doctors in our team. I go and visit a lot of patients myself. I've never made a comment like that. I've never heard any of my staff or colleagues make a comment like that. I'm sure why on earth we would make comments like that. So I was completely surprised, and agree with comments about complaints. And we have a large file full of thank you letters, which overwhelm any problems that there have been.
Okay, thank you very much. Thank you.
Can I thank the panel very much for their comprehensive responses this morning. The committee is now going to go into private session. Order.
Cullis House, the Thatcher Room.